So next up, we have Einar Gunnarsson. At least I think that's correct. Oh, you're next, right? I couldn't remember if it was correct.
Can I actually
you.
grab this? Yeah, thank you. So I'm from the University of Iceland, and we've been talking a bit about the weather, how nice it is. I want to begin by just showing you what's going on in Iceland at the moment. So this picture is taken yesterday. It was the first big snowstorm of the year. And you can see a car here which went out on summer tires, tried to drive uphill, couldn't do it, turned around, and now it's driving onto the oncoming traffic and trying to reverse when the picture is taken. This is another car in a very unfortunate situation, trying to go up in a parking garage on summer tires, and I don't know if you can get any more stuck than this. But to not deter you too much from visiting Iceland, we do have some nice stuff. We have some volcanoes. We have volcanoes with northern lights. So please come and visit, but just do it in the summer. That's kind of the lesson here. But to get into the science, so I'm going to talk about drug-induced persistence in cancer. And our scientific story starts with this paper by Sharma and colleagues from 2010, where they identified what they called a drug-tolerant persister state in non-small cell lung cancer. So these drug-tolerant cells were able to survive drug treatment at a very large dose. And then when you took the cells off drug and allowed them to expand for a little bit, they regained sensitivity to the drug. So indicating that this drug tolerance was reversible. But in the Sharma paper, the authors drew an analogy with persistence to antibiotic treatment, which is very well known in bacteria. But in bacteria, the persistence is usually thought of as pre-existing, meaning that persistence will already be there when the treatment is started. But a few years after the Sharma paper, a math modeling paper actually showed that the data in that paper could also be consistent with a drug-induced model, meaning a model where the drug was actually pushing the cancer cells to become persistent. And these authors also suggested follow-up experiments that could be done to distinguish between pre-existing and induced. And on that topic, a few years later, this paper by Russo and colleagues suggested to use Bayesian model selection to distinguish between these two alternatives, pre-existing and induced. And so basically, they compared a math model where the initial fraction of persistent cells was said to be 0, or where that parameter was allowed to be free. And they used model selection to conclude that the formal model was more parsimonious. So they concluded that the persistence was predominantly induced by the drug, as they put it. And we also have recent work on this topic where we showed how we can use high throughput drug screening data to first of all tell whether there is drug-induced persistence, and secondly, to infer the parameters of the model. So including how fast the cancer cells are adopting persistence. And so here you can see an example of an experimental data set we looked at in this paper. So we have melanoma cells here treated with 5 different doses of emirafinib and also a control condition. And you have monitored over time how many cancer cells you have in the population under each of the conditions. And so we fit a math model to this data, and then we used model selection to conclude that the drug actually did induce persistence in this cell line. But the nice thing about this approach is that it allows you to detect drug-induced persistence without knowing anything about the biology, about the mechanism. But that information is still useful for making treatment decisions, as I'll talk about in a little bit. But next, I'm going to show you how we're going to model drug-induced persistence. So we're going to assume that we have a heterogeneous tumor where each cell in the tumor can transition between 2 states, a drug-sensitive and a drug-tolerant state. And each drug-sensitive cells can divide into 2 cells, die, or transition into be drug-tolerant. And similarly, each drug-tolerant cells can divide, die, and transition back to sensitivity. And we're going to assume that the tumor is being treated by a cytotoxic drug, so the drug is going to increase the death rate of the sensitive cells as a function of the dose. But because we're interested in drug-induced persistence, we're also going to assume that the drug affects the transitions between the phenotypes. And there, we're motivated by this experimental paper and colleagues that I mentioned before. So I said before that they used Bayesian model selection to distinguish between pre-existing and induced, but they also used it to distinguish between different potential forms of drug-induced persistence. And for one of the cell lines they studied, which is shown here, they found that this rate here of switching from sensitivity to persistence actually increased linearly as a function of the dose. We're going to call it linear induction of tolerance. And for the other cell line, it increased what I called uniformly as a function of dose, meaning that the drug effect was the same whenever you were applying any drug. But in this Russo paper, the authors basically assumed that the drug could only affect the transition from sensitivity to persistence. But from a biological perspective, it's also plausible that the drug can inhibit the reverse transition from persistence back to sensitivity. And the drug could also be affecting both simultaneously. There's actually some experimental evidence happen. So we're also going to assume that the drug can affect the reverse transition, that it can do it linearly or uniformly. But to just very briefly give you some intuition for how this model works, I'm going to show you an example of how the tumor evolves under a low dose versus a high dose treatment. And for simplicity, I'm going to assume that the drug is only affecting this transition and that it's doing it linearly or gradually. So in this case, when we apply a small dose, we're going to be killing the drug-sensitive cells slowly. But because the sensitive cells are adopting persistence, we're also creating persistent cells, and they're going to drive slow growth of the tumor in the long run. If we apply a large dose, we're going to kill the sensitive cells faster than under the low dose. But because the transition from sensitivity to persistence is increasing linearly, we're going to induce way more drug-persistent cells than in the former case. So actually the tumor is going to be larger in the long run under a large dose than a low dose. So here it's actually better to give a low dose. But in general, the evolution of the tumor under treatment depends entirely on how we administer the drug. And we don't necessarily have to give a constant dose like I was showing you before. And what we're interested in here is the optimal way to administer the drug. So we want to the dosing schedule that leads to the smallest possible tumor size at the end of a treatment horizon. Okay, but just to summarize before I go to the results, we have this mathematical model where each cell is able to transition between a drug-sensitive and a drug-tolerant state. And the drug can affect one or both of these transitions, and it can do it linearly or uniformly. So actually in this model, we have a lot of different forms of drug-induced persistence. And one of the goals of the study is to figure out what these different forms imply for the optimal treatment. Okay, but let's look at some results. So first, I'm going to look at linear induction of tolerance. And I'm going to assume that the drug is only affecting the forward transition, and it's not affecting the backward transition. In this case, it's actually optimal to just give a low constant dose from the beginning. And I'm going to ask you to ignore this final part here. This is basically a technical thing that doesn't matter for our discussion now, at least. Okay, if we, on the other hand, assume that the drug only affects the reverse transition, in that case, it's actually optimal to start with the maximum possible dose and then gradually lower it over time. And the reason that we get different optimal solutions in these two cases is that in both cases, most of the cells are sensitive when you start the treatment. And in the former case, in this case here, you don't want to start with large doses because then you're going to be pushing a lot of sensitive cells to adopt persistence as you're killing the sensitive cells. Whereas in the second case, we're not affecting this transition, so we can get away with giving larger doses in the beginning. And if we assume that the drug affects both directions, we get sort of a compromise solution. Well, we do want to give larger doses in the beginning, but we don't want to start with a maximum dose. But in this slide here, I've gathered all of the three cases, and we're going to think a little bit about what the cases have in common. The first thing that you see is that in all three cases, it's optimal in the long run to give a constant dose, a low constant dose. And we can actually prove mathematically that this constant dose, that's called C star here, minimizes the so-called long-run growth rate of the tumor, which is something we can compute explicitly. But second, if we look at how the proportion of sensitive cells evolves over time in the tumor, we can see that in all three cases, in the beginning, most of the cells are sensitive. Then during the first part of the treatment, as we're killing the sensitive cells, this proportion lowers. But then when we get to this constant dose phase, we're actually maintaining the tumor at a fixed proportion between sensitive and tolerant cells. So one of the results of this study is that there is some optimal composition between the two cell types, the one which leads to the lowest long-run growth rate of the tumor, And we can say that the goal of the optimal strategy is to push the tumor to that composition and then keep it there in the long run. Okay, but I don't have time to go too much into the weeds of the results. I'm just going to mention briefly that we've already seen that under linear induction of persistence, it's optimal either to give just a low constant dose or to start with larger doses and then give a low dose in the long run. And if we look at the uniform induction that I also mentioned before, there it turns out to be optimal to either just give the maximum dose continuously or to alternate between the maximum dose and no drug. And this is intuitive because under uniform induction, as soon as you start giving any dose, there's no downside in just pushing the dose to the maximum dose. You're not going to be inducing any more persistence. But one important takeaway from this is that it depends a lot on the specific form of drug-induced persistence, what the optimal strategy is. And that creates a bit of a problem for treatment because, as we know, cancer, it varies a lot between individual patients. So the question is, if we want to actually apply these insights, we have to have some way of figuring out what case applies to which cancer type or even an individual patient. And one way in which we might accomplish that eventually is to integrate math modeling into preclinical research, as many of the speakers have talked about already in this conference. So there the idea is that you have some in vitro model of some cancer, you do experiments, you use the experimental data to develop a math model to infer the parameters, and then using the tools that I was just discussing, you can use the model and the parameters to derive the optimal schedule. That gives you a treatment recommendation that you could then investigate or test further, either preclinically or clinically. But I also plan to think more about whether I can integrate this with clinical data directly. So you can kind of see from the results that there are two regimes that are forming. One where it's optimal to just give a low constant dose in the long run. One where we only want to give the maximum dose whenever we're applying the drug. And the question is, if we don't have access to the kind of data we need to know exactly what the model is and what the model parameters are, can we get enough information to at least tell which regime we're in and if we should rather be giving low doses or high doses? But so I just want to conclude by acknowledging my co-authors. These are the two papers that I mentioned. Otherwise, thanks for your time. I'm happy to take questions.
Yeah, very interesting. I have a question. So, do you have a particular tumor in mind, and what are these persisters? If you're looking at them, because I imagine it's sort of everything kind of depends on the details of this. So one thing that it reminds me of a little bit is stem cells and more differentiated cells, where the bulk of the tumor is more differentiated and they're the susceptible cells, and stem cells are kind of resistant to treatment. And there are data that show that when you give chemotherapy to patients, that you drive those stem cells into proliferation, you amplify them, and that induces this sort of persister phenotype. In this case, it would depend on, I mean, chemotherapy, you can't keep dosing in one go, you have to give it in cycles and so on. So how do the particulars enter your optimal schedules?
So from my perspective, like the model is quite generic. Like any case where you could describe the situation with these dynamics, my analysis would apply. But I would say that the motivation is more from the targeted therapy space. So like both this paper by Sharma and the paper by Russo were looking at targeted drugs. And I remember that in the Sharma paper, the mechanism seemed to be, it had something to do with methylation of a lysine of some histone. So it's like, it seems to be epigenetic forces that are driving the changes in this case. But I could foresee that having stem cells and differentiated cells under chemotherapy, this might also apply to that.
Hey, it's a beautiful nonlinear system you have developed there, and you went immediately in showing us some treatment response dynamics. Can you comment on what this system looks like without any treatment? What are the evolution of these two phenotypes, and how dependent are these kind of results you're getting on the parameters you put into your model?
So if there was no induction of the drug, you mean, or
No treatment whatsoever, right? You have two different populations.
yeah,
They interact, they move, phenotypes, they divide, they die, whatever.
yeah.
What does this dynamic model look like without treatment, such that we can actually decipher what's the contribution of treatment to the dynamics we are seeing here?
Okay, so if there's no drug, what happens in the long run is that you get exponential growth and you get fixed proportions between the types.
Or a specific set of parameters.
Yeah.
For other parameter sets, you don't get consistent exponential growth. Right. For example, if you have a massive death rate and a low proliferation rate, you don't get exponential growth.
You get exponential decay in that case.
So,
but
there is a certain parameter combinations and functions you choose here that give you very interesting dynamics. And I just wonder, your optimal treatment, is whatever you defined as optimal, will this still be optimal for different parameter regimes?
So, okay, under each fixed dose that you give, you have fixed parameters in the system. And so in that case, you get either exponential growth or decay. And of course, the magnitude of the rate is going to depend on the dose that you're giving, on the parameters. And so I would say, like, if you think in terms of giving a constant dose, just to keep things simple. So for each dose, you would get a long run growth rate that's coming out of that, which it's either going to be exponential growth or decay. And then you could just look at a one-dimensional curve of the growth rates and identify the dose that gives you the lowest growth rate. I don't know if it's answering your question, but yeah.
Thank you very much. Great. Let's thank the speaker. Asking a lot of my vision here, so.